Struggling to get pregnant and wondering what's wrong? You are not alone. 1 in 6 couples is impacted by infertility. But here's the good news. If you can understand the root cause, you can meet your goal sooner. Today, I'm going to break down the top 5 causes of infertility in women, how they're diagnosed, and how to treat them. I'm Dr. Lora Shahine. I'm a double board certified OBGYN and reproductive endocrinologist helping people with infertility for 20 years. I am always trying to find the cause and fix the issue of infertility to help my patients meet their goal sooner. Helping with this understanding can help you advocate for your own care. I'm so glad you found this channel. If you are new here, be sure and subscribe so you get my weekly videos all about reproductive health. I love educating. There's 2 other ways to stay in touch and stay informed. Number 1 is my weekly newsletter. I'll put a link in the description below. You get fertility news, information, recommendations, and new educational content every week. The second way to learn is my weekly podcast, the Brave and Curious podcast. I do deep dives into topics and I have interviews with experts in the field. You can listen anywhere you listen to podcasts. Today, we are going to talk about the 5 most common causes of infertility in women. We're going to go through each cause, how it can show up, how you diagnose it, and how you can treat it. Now stick around to the end of the video where I'll give you 3 important questions to ask your doctor about your personal situation. Let's get started. Cause for infertility in women, number 1, ovulatory dysfunction. Ovulatory dysfunction can account for about 25 to 30% of infertility in women. What is that? It means not ovulating regularly. It most often shows up with irregular and unpredictable menstrual cycles. It is absolutely amazing with all the communication that happens from the pituitary gland to the ovaries and the uterus and back and forth that we have pretty predictable and regular menstrual cycles. Less than 25% of people actually have an exact 28-day cycle. But if you are ovulating about once a month, you get a period about once a month. In the middle of your cycle, the body releases an egg and then the ovary starts making these hormones that help support a pregnancy if you're pregnant. But if you're not pregnant and the ovary drops its production of estrogen and progesterone, that signals the shedding of the lining of the uterus and the start of a new period. So it is amazing, and this is why people call a regular menstrual cycle a vital sign, because if you're having a period about once a month, that means that you're ovulating. Not always, and of course you need to talk to your doctor about your personal situation, but typically people with ovulatory dysfunction will not have a monthly cycle. A little bit of variation is okay. Sometimes it could be a 28-day cycle, sometimes it could be a 31-day cycle. But people who are skipping cycles and say, gosh, I could maybe not get a period for 2 or 3 months, or I could have 2 episodes of bleeding in a month. If it's not pretty regular, that is a sign of ovulatory dysfunction. There are many causes of ovulatory dysfunction. So when you're thinking about a diagnosis or kind of how to figure this out, if you are not having a regular period, you probably have ovulatory dysfunction. So I can get that information just talking to my patients. But then I want to think about why. The most common cause of ovulatory dysfunction is polycystic ovarian syndrome, or PCOS. Impacts 1 in 10 reproductive age women. It is a metabolic disorder, shows up in many different ways. I've got multiple videos on YouTube teaching about PCOS, but it is the most common cause of ovulatory dysfunction. Other things that I think about and tests that I run are looking for thyroid disease, prolactin dysfunction. A cause for ovulatory dysfunction that can be kind of scary, but you've got to think about it, is running low on your egg supply. So sometimes getting close to menopause or in perimenopause will start to have ovulatory dysfunction. And a final cause of ovulatory dysfunction is something that's really hard to nail down. It's not a very specific lab result, but it can be stress. It can be low energy supply, over exercising. Sometimes this is called hypothalamic hypogonadism. It's sort of a diagnosis of exclusion, but you think about hormonal dysfunction, PCOS, you think about energy levels, stress, you really try to find out why someone is not ovulating regularly. And so treatment for ovulatory dysfunction is trying to treat the cause issue, the root cause. If that still doesn't work, then sometimes I can prescribe medications to help my patients ovulate. So if there is no root cause or you're treating it and there's still ovulatory dysfunction, someone's not ovulating regularly, we can give medications to induce ovulation. So you might have heard of Clomid or Clomiphene or Letrozole. The brand name is Femara. These are pills that can help recruit an egg, and then we can trigger ovulation with another medication called a HCG, or a trigger shot. It's a little subcutaneous shot. So there are medical ways that we can induce ovulation and help time trying to improve the chances of getting pregnant and shorten the time to conceiving. Of course, there's lots of fertility treatment options: intrauterine insemination, IVF. So sometimes people will use these treatments with ovulatory dysfunction. But my thinking is try to get to the root cause. If you can help somebody ovulate on their own regularly and there's no other cause for infertility, it might happen with simple means, but you do have other options to help you meet your goals on your terms. Cause for infertility in women, number 2, Tubal Factor. This means that the egg and sperm cannot meet each other because the tubes are blocked. It's estimated that this can account for 20 to 25% of cases of infertility in women. This can show up without symptoms. So people might not have pain and they can have perfectly regular menstrual cycles and still have blocked fallopian tubes. So this can be a silent cause of infertility. The way it's diagnosed is with a test. There's a test called a HSG, or hysterosalpingogram, where fluid is flushed into the uterine cavity, and under fluoroscopy, we watch the fluid go through the fallopian tubes. The tubes are so small and they're so delicate that you cannot see fallopian tubes on imaging like an ultrasound or an MRI. And even if you could see them, the fallopian tubes are like pipes. You can't tell if they're open or not unless you watch fluid go through the pipes. I've got some educational content on YouTube, some wonderful videos that explain the HSG test in detail. The other way to diagnose fallopian tube issues is with a laparoscopy. So that's much more invasive. That's surgery where a camera is placed through a hole right near the belly button to look into the pelvis. And you can place a tube in the cervix, or the bottom of the uterus, and have fluid flush into the uterine cavity and spill through the fallopian tubes. But you can watch it from above from the laparoscopy. So that is a more invasive way, but if you are doing a laparoscopy for other reasons, you could ask your pelvic surgeon, hey, can you flush the fallopian tubes and make sure that they're open? But again, an HSG or a laparoscopy are really the only ways to know that the fallopian tubes are open. There are some other in-office procedures with saline and ultrasound that can watch fluid flush through the fallopian tubes, but traditionally the HSG and laparoscopy are the two main ways that have been studied the most. Treatment for tubal disease. Well, if you know exactly why the tubes are blocked, you would love to be able to fix them. So laparoscopy might be able to identify some adhesions around the fallopian tubes that if they're lysed, it might allow the tubes to be open and flush. But honestly, fallopian tubes are so delicate that most of the time surgical interventions do not result in success. It can often result in more blockage of the tubes. It may be worth a try, but a lot of times people have turned to IVF as a way to treat tubal disease. That is why IVF was invented. IVF, in vitro fertilization. The first baby born in 1978. Her parents had tubal dysfunction, and they were unable to fix the fallopian tubes, and IVF at its core is a way for the egg and sperm to meet outside of the body. In vitro means in the lab fertilization. So get the eggs from the body, get a sperm sample, help the eggs and sperm fertilize in the lab, and when the embryo is ready, put the embryo into the uterine cavity, and by placing it through the cervix and into the uterine cavity, so people can get pregnant without fallopian tubes. So at its core, IVF was invented for tubal disease. Cause for infertility in women, number 3, endometriosis. Endometriosis is a chronic inflammatory condition in which tissue that looks like the uterine lining is found outside the uterine cavity and throughout the pelvis, through the abdomen, along the fallopian tubes, maybe in the ovaries, and other parts of the body where this tissue really should not be. We are still learning so much about endometriosis. It's estimated that 10% of women have endometriosis, and it's estimated that if somebody is diagnosed with endometriosis, 40 to 50% of the time they will have difficulty conceiving. So not everybody with endometriosis will have infertility, and not everybody with infertility will have endometriosis, but it is something that I am always thinking about when I'm talking to my patients. Diagnosis is tough. The only academic and researched way to definitely diagnose endometriosis is to see it. So with a laparoscopy, again, the little camera and the belly button, looking into the pelvis and finding this tissue that really shouldn't be there, that is a definitive way of diagnosing endometriosis. There are other ways to get a clue that someone may have endometriosis. I ask about symptoms: pain with intercourse, pain with periods, urinary and bowel changes around the timing of a menstrual cycle. Changes in hormone levels often increase symptoms that are associated with endometriosis, and it's something that you have to ask about. It's something that you have to think about. And so many times women have just been taught time and time again to dismiss their symptoms around their period because it should just be awful, and maybe that's the way it was in their family. But it doesn't have to be, and it's important to find a provider that is going to listen to you and ask these questions and have endometriosis kind of as a little bit of a red flag and think about it. So symptoms can diagnose it. Of course, laparoscopy is a definitive way. There are other methods that are, still being studied. There's an endometrial biopsy that you can look for a marker called BCL6, that if it's found in the luteal phase and an endometrial biopsy at a certain level, it can be associated with endometriosis, but that's not 100% diagnosis either. Treatment for endometriosis. Well, it depends on if you're trying to get pregnant or not. If you are not trying to get pregnant, a lot of medication and medical therapy that will decrease estrogen levels and decrease ovulation will really result in decreased symptoms like pain and a lot of the things that I just described. But if you're trying to get pregnant, a lot of the medical therapy for endometriosis is going to make it harder to get pregnant. So that's not going to be helpful. Some people will do laparoscopy to not only definitively diagnose endometriosis, but also remove the lesions and have symptoms relieved, like pain or like some of the other symptoms that I described, and it can improve fertility. Some people will use fertility treatments to try to conceive faster, like intrauterine inseminations or IVF, as a way to bypass some of the reasons that endometriosis causes infertility. Your path is so dependent on your personal situation. So you need to talk to your doctor about, hey, do you think I have endometriosis? Do you think this can be a part of my fertility picture? If so, what would you recommend for my personal situation to help me get pregnant sooner and to help me meet my goals? Cause for infertility in women, number 4, diminished ovarian reserve. Now, this is a tough thing to talk about because there's actually not a universally agreed upon academic definition of diminished ovarian reserve. In general, it's considered having a lower egg supply than you would expect for your age. It is more common in women that are over the age of 35, but people can have diminished ovarian reserve in their 20s or even younger. It's often associated with having a lower than expected average of AMH. AMH is a blood test, anti-Müllerian hormone, that in general can reflect the number of eggs that are up for grabs each month. You can get a diagnosis of diminished ovarian reserve with an ultrasound where the provider is looking at the ovaries and counting the number of resting follicles that are in each ovary. On average, people have 10 to 15 resting follicles on their ovaries anytime in the menstrual cycle. And if it's below average for your age, you could be diagnosed with diminished ovarian reserve. Sometimes people aren't diagnosed with it until after they go through an IVF cycle and they get fewer eggs than you would expect for their age or even their AMH level. So it is a very general term. And not everybody with a low AMH or a low antral follicle count will necessarily have difficulty getting pregnant. So it is something to consider and think about and talk to your doctor about your test results. I would consider getting an ultrasound with an antral follicle count and a blood test for AMH, anti-Müllerian hormone, And then we're doing this less than we used to when I started my practice 20 years ago. But a cycle day 3, FSH, follicle stimulating hormone, and estradiol on the same day. And it can honestly be done cycle day 2, 3, or 4. If that is higher than 10, if your FSH level is higher than 10 in the early part of your menstrual cycle, or your estrogen level is much higher than it to be expected during that time, like over 80 picograms per ml, then that could be associated with diminished ovarian reserve. It is, so hard to put a label and a box around diminished ovarian reserve and really predict what's going to happen for each individual person. But people with a high FSH or a lower than average AMH for their age often can take longer to conceive. Not always, but getting this information kind of early in your fertility journey can help you make long-term decisions. Again, a low AMH and a low FSH does not mean that you cannot get pregnant. I tell my patients every single day, no matter what your age or what your lab levels look like, as long as you have all the components, you are ovulating, you've got sperm exposure, and at least one fallopian tube is open, then anything is possible. But if you get this information, you can talk to your doctor about your family goals and what these numbers mean for your personal situation. Because if you do have diminished ovarian reserve and you want a big family, you might want to be more aggressive sooner rather than later. That does not mean that everybody has to do IVF, but I really think that people should get educated and get knowledge and know what their options are so that they make the right decision for themselves. And cause for infertility number 5 in women, unexplained infertility. This is one of the most frustrating and difficult discussions to have with a patient because been trying to conceive, whether it's 6 months, whether it's 12 months, it's just not happening. Regular cycles, they are ovulating. Test results look reassuring. Semen analysis, perfect. Anatomy checkup, normal uterus. Both fallopian tubes are open. Unexplained infertility means you have all of the parts to conceive. You're ovulating, sperm exposure, at least one fallopian tube is open, and it's still not happening. Of course, there is a reason why you're not getting pregnant, but we are still learning so much about fertility. This is still a relatively new field of medicine, and we are still learning so much about it. So when we're doing an evaluation, we're really just doing the basics. Are there eggs? Is there sperm? And can they find each other? And unexplained, of course, there's a reason why you're not getting pregnant, but we just don't know why. Sometimes it could be something different happening each cycle. Sometimes you could ovulate a perfect egg and the one sperm that gets in is just not a perfect sperm. Or sometimes you ovulate, but the egg doesn't even get into the fallopian tube. Like if you think about all of the things that have to go right for us to conceive, it's amazing that any of us are here, but it does happen 60% of the time in the first 3 months of trying for most couples, 85% of the time in the first year of trying for most couples. So if you really meet this unexplained infertility diagnosis, my heart is with you. I know it's frustrating, but there is still treatment options available. It could be considered low-tech treatment, like some medications to induce ovulation, help make sure you're ovulating on time with a trigger shot, and doing an intrauterine insemination. Or one of the most common reasons people actually do IVF is because it's controlling for so many more variables and you're working with multiple eggs in one cycle. And then the attrition part of IVF, which is really hard because not every egg and not every sperm is going to turn into a beautiful embryo that's going to turn into a baby. But that attrition, you could get 12 or 15 eggs in one cycle, and that could result in 3 or 4 embryos. Each time you transfer one of those embryos, it's a much higher chance of success because you really narrowed it down to the embryos that have the highest chance of implantation. So my heart is with you if you have been diagnosed with unexplained infertility. I think we still have a lot to learn in fertility and doing better diagnosis for people, but we still do have treatment options, and talking to your doctor about the right path for you is crucial. I'm glad you stuck around to the end. I hope you found this valuable. Let's do a quick recap before I give you 3 important questions to ask your doctor. Today, we reviewed 5 most common causes of infertility in women. We went through how common each cause is, diagnosis, and treatment options. Number 1, ovulatory dysfunction. Number 2, tubal disease. Number 3, endometriosis. Number 4, diminished ovarian reserve. And number 5, unexplained infertility. Now that you've got this knowledge and you're going to see your doctor, here are 3 questions that I want you to ask. Question number 1, what tests do you recommend for me and why? Kind of go through each test and think about what it's going to show, what questions you're looking for, and how it's going to help you get your answers. Question number 2, do you recommend that I see a fertility specialist, a reproductive endocrinologist? And if so, when? Or if you don't recommend it right now, when would you recommend it? Ask about a plan. I see a lot of patients that wish that they had come to see me sooner because primary care doctors and wonderful obstetricians and gynecologists have incredible hearts and they're trying so hard to help you, but I do infertility and fertility treatment every single day. So I do think about things a little bit differently and I offer things in a different way. So ask the question, do you recommend a referral to a reproductive endocrinologist now? And if not, when? Question number 3, what treatment do you recommend for my personal situation? And see what they say and ask why they recommend that specific treatment. And then hit them with, okay, if this were you or you were counseling your best friend, what would you recommend for them? Because I feel like there's a lot of doctors out there that give like this huge options, but don't really narrow it down for the patients. I want patients and physicians to partner. I want to partner with my patients. I want to say, hey, here is what I think is going on. Here are the treatment options. You could do all these different paths. And you know what? If it were me, I would take my 20 years of knowledge and I would do this. And if the patient and I are aligned, great. And if we're not, I want to answer that patient's questions and I want to honor what path they choose and help them along the way. I hope you found this information valuable. I want you to take away tips that you can help in your own personal situation. If you learned something today, like this video, comment with questions that you have, and be sure and subscribe to this channel so you get my weekly videos all about reproductive health. And until next week, wishing you love, luck, and pineapples.